This video presentation is about shoulder pain, how to make the diagnosis. I am Mayor Lloyd, Ireland, with the Department of Orthopaedic Surgery and Sports Medicine at the University of Kentucky, and it is with pleasure that I show you these slides, many of which are cases that I've taken care of over the years in my orthopedic practice. Posterior instability. Ask the patient what causes them to have clunking of their shoulder. What he's doing now, putting his shoulder into horizontal adduction, arm into horizontal adduction, internal rotation. If he had posterior instability, we would be able to see. The patient can demonstrate it sometime better than we're able to examine. So this could be a habitual posterior instability or a multi-directional instability. So if they're able to reproduce their instability, that is a good way for you to make the diagnosis. Sometimes they can do it better than we can reproduce it when we're examining them clinically. So moving the arm into internal rotation, horizontal adduction, there'll be a clunk, and there can definitely be an asymmetry one side compared to the other. So ask the patient to read. The bone posterior instability test, so you're stabilizing the scapula and basically just pushing the humeral head to the back. And you can see here where I've got his scapula stabilized, and I can push on his posterior capsule and see if there is indeed instability. Going the other way, externally rotated, backward flexion would tell me about anterior instability, and I can stabilize the scapula in this way. So an apprehension test going into external rotation, backward flexion indicates anterior. If we can pop it out the back, or he has pain or a clunk or a pop in the posterior aspect, applying axial load posteriorly, that tells me that there's more of a posterior instability. So this is a great prone test that we should do on all instability. What leads laxity to instability? We see certain athletes, female athletes, swimmers, cheerleaders, gymnasts, tennis athletes who have multi-directional laxity. When they come in and have a clinical complaint, that will become instability. And what our charge is to figure out the chronicity of it. Is it voluntary? Is it asymmetric? And what is the direction of the instability? Is it posterior, anterior, inferior, or multi-directional instability? So this is a vicious cycle pathway that I feel leads to the rotator cuff weakness that we see in swimmers. So it starts off with a physiologic laxity, and if you follow me in this clock face, you get capsular distraction, microtraumatic stretching of the capsule, if you will, usually not that Bankart lesion or that anterior labral detachment that we see in the football player, but then you get rotator cuff dysfunction, then you get more capsular ligamentous stretching or labrum tear, but because they're so loose to start off with in these multi-directional laxities, they stretch the capsule out as opposed to knocking off the labrum or knocking off the bumper in the front. Then you can get a partial rotator cuff tear. Then you can get more subluxation of the humeral head, either voluntarily or with the nature of their repetitive sport. Can go in the front, back, inferior, and then this develops into pathologic instability. So we try to diagnose these problems early, put them on a proper biomechanics of their sport, strengthening, scapular stabilization program. And in advances in arthroscopy, we haven't been as successful with working on the capsule as we have as something is knocked off, such as the labrum with anterior inferior glenohumeral ligament. That's very successful, treated acutely with arthroscopy. So this is a multi-directional instability patient. His scapula are symmetric. They do look a little like they're winging, but scapula isn't his problem. So have them do a push-up on the wall to assess the scapula. And now he's able to reproduce his posterior instability. You can see how his scapula, which connects to the glenoid, follows this. And as we put this skeletal model over it, you can better appreciate what he does. So he posteriorly subluxes voluntarily. So now I've got him supine. I'm inferior subluxing him. And then you can see where, again, I hold the acromion, and you can rock him out and then reduce him. I'll ask him to sit up straight and do it again, rock him out, and reduce him. So this is a posterior instability. So again, levering, rocking him out, and then going back in, rocking him out, and then going back in. So this can be, in his case, more of a voluntary posterior instability. And then you can do manual muscle testing of external rotation, internal rotation, have them put their hands on their waist to, again, better look at their strength, but also to look at the scapula. So he does tend to wing, which is symmetrical. This is his non-involved side, his left side. And again, this is a multi-directional posterior laxity on the left and instability on the right because he's having This individual had an open anterior reconstruction that clearly was not successful. You can see her sag sign, you can see her acromion that's sitting up there in the breeze, and her humeral head is dislocated basically at this point. Look at her keloid formation from this anterior stabilization procedure that I did not do. She's actually more symptomatic from the standpoint of instability on the side that was operated on. So now her humeral head is inferiorly subluxed. This is her normal side. So you can see the anterior-inferior instability just with gentle traction on her arm. See the asymmetry there where she's greater inferior luxed on her right than her left. We ask her to move her shoulders around. She's not very happy we're taping her, but one of the things she does is she's in this forward head kyphotic thoracic position, which makes her scapula be in a poor position for stability. So in her case, we started on a rehab program, put her in a figure of 8 splint to keep her shoulders back. And you can see when she goes forward, her humeral head comes out. And then if she does shrug her shoulders together, it's in a much better position, as shown here on the left, forward, and on the right, just asking her to put her scapula together and sit up straight, open up her chest. She is now in a better position. Beware, don't operate on. This is an 18-year-old right-hand dominant discus thrower who threw the discus, felt a pop. She was unable to move her arm. She went to the emergency room. We don't usually see x-rays showing a posterior dislocation, but in her case we did get a posterior dislocation in the ER with a good axillary lateral view. Posterior dislocations are still missed in emergency rooms. Typically, it's a more violent problem than throwing a discus. So this patient had underlying multi-directional instability. Usually a posterior dislocation that is fixed is in an individual who has had an electrocution, has had a seizure, or may not be completely with it, and that's probably why these are missed. This is her axillary lateral view. Great axillary lateral view for an emergency room. You do need to have an AP and a 90-degree different view. So you need an AP and some type of a view lateral to tell if the shoulder is dislocated or reduced. So the arrows are on her glenoid, and you can see here where her humeral head is out the back. Always look at the coracoid in the front. That gives you a good landmark of what is anterior, where the coracoid is, or posterior, where the acromion is. So this is her exam under anesthesia. You can see we can move her arm any which way but loose, about all the way around 360 on that clock face. So you can do this crank test of her proximal humerus, or you can lever her in and out of place as we've been talking about with our physical exam. So get under the deltoid, lever out the back. So she's more unstable posterior, which would be the direction that we're going to particularly look at and fix if we can, either an open way or arthroscopic. So you can see her jumping posteriorly out the back when we're examining her under general anesthesia. So this is her view, her externally rotated view, axillary lateral view, and then this is a posterior dislocation, which we rarely see on the axillary lateral view, but in her case we could see it. This is a Stryker view that is normal in the bottom, but if you look at the difference, the asymmetry where you see there's a lot of space between the glenoid and the humeral head, that's a patient who has a posterior dislocation, but you do need some type of a lateral view to document that, and you don't want to miss a posterior dislocation because it's very difficult to reduce them and give them a normal shoulder if it's missed for a long period of time, which sometime it is, unfortunately, still to this day.